Usually we do things in conjunction with some pharmacologic things, or frequently the patients already have been doing some pharmacologic on top of their potentially non-pharmacologic things they may have tried. Usually the first line, and most guidelines will agree that first line for therapy would be acetaminophen, having to be careful about kidneys and liver in people who may have other conditions that go along with that. Some people will then move on to anti-inflammatory drugs. We use these, but many times, particularly in osteoarthritis, when people are of an older age, they may have other conditions that make it difficult for them to take anti-inflammatory drugs because of cardiac side effects or kidney side effects or stomach ulcers and those kinds of things. Sometimes we'll use topical anti-inflammatories in that setting because the absorption is less, and so there'd be less likelihood of having some of those side effects. So most of the treatments that we have influence symptoms, and some better than others. But some of the more exciting things that are happening now are really trying to get at some of the inflammation that is present in OA, and particularly for knees, the thought being that intra-articular, that is something that's injected into the knee itself, may be a better way to go than by giving someone pills or things like that, that again may interact with other medicines that they're on or may have problems based on other diseases the person may have. So there are several different things that are undergoing testing still that look at different kinds of growth factors that could be injected into the knee to try and get cartilage to regenerate, which is not usually what it does, and to more likely stop degradation of cartilage and other bone and soft tissue structures. This actually affects all physicians and caregivers for osteoarthritis. Rheumatologists definitely can't do this alone. About 50% of people with osteoarthritis, really their main care resides in the primary care office. We tend to see in rheumatology people who are either not doing well or having more difficulties or have a question of maybe there's something else going on, either in addition or instead of. Really, it's a huge problem that's coming upon us. There are estimates up to the year 2030 that we're going to have over a 600% increase in their demand for knee replacements if something doesn't happen with being able to treat osteoarthritis more effectively. We can't possibly train that many orthopedic surgeons, nor would we want to feel like we had people lined up down the street to get their knees replaced. And so the real need for finding a disease-modifying drug in osteoarthritis is a huge one right now.